Hello, Doctor. This is an overview of the Mastering the Gut Gastrointestinal Function Assessment Form for patients to fill out. In this overview, we will discuss each section and break it down to make it more usable and understandable in your everyday practice. This customized assessment form will help you prioritize the patient's gastrointestinal condition, enabling you to create a treatment plan specific to their needs and their priorities. They can fill out this form online on their electronic device and then email or fax it back to you or print it off as need be. The patient's health concerns are the reason for them to come to your office. They have often already self-diagnosed themselves with the latest diagnosis du jour by the time they seek your help. This section allows you to see what their mindset is and what motivates them. In this section, the patient is asked to list their 5 major health concerns in order of importance. This section is used to merge your treatment plan and the patient's health concerns during the consultation. By explaining how the treatment plan addresses their priorities, the more compliant they will be. If they have already listed their major health concerns on another form, there's no need for duplication and they can omit this section. There are a vast variety of diets, too numerous to list. This section provides a basic overview of different diet styles. What style of diet is your patient consuming? This section allows you to see what the patients think they are eating and how often they think they are eating it. What supplements and medication is the patient taking? Be aware that they often will only list the ones that they think you need to know about. Have them take a picture of their supplements and medications. Are they taking antacids or acid blockers? This is important to know when recommending protocols to restore the production and sequencing of digestive chemistry. Probiotics or prebiotics. This is important to know if the product they are taking is acid-proofed and what the growth stimulator is. You should also be aware of the probiotic paradox, where once a condition is initiated and becomes chronic, probiotics will only maintain the condition rather than restore health. Prebiotics can also cause a microbial bloom or promote SIBO. Inulin is often used as a growth stimulant and can be problematic, causing severe reactions. This is covered in the probiotic unit of the Mastering the Gut program. Section 1. Gastrointestinal Supplements. How does the digestive support make the patient feel? Much worse? Worse? The same? Better? Or much better? If the supplements are making them worse, they need to be reevaluated by considering the brand of the supplements used and their physiologic effects. This section should be compared to following sections, because if the patient marks better or much better, but in the following sections have high marks in the various sections, it brings into question the severity of their condition prior to the supplements or their current condition, because it may be the perception of improvement because of what they're reading on the internet in seeking to find social proof for their supplementation. Section 2. Abdominal adhesions. When abdominal pain is chronic and unremitting, without any significant relationship to eating or bowel function, but often occurs with a relationship to posture, i.e., lying, sitting, standing. Abdominal wall adhesion should be suspected as the source of pain. It can occur also in athletes, as they have been found to develop abdominal wall pain related to myofascial tears. It can also occur as idiopathic intra-abdominal adhesions. As the body moves, tissues or organs inside are normally able to shift around each other. This is because these tissues have a slippery surface. Inflammation, swelling, surgery, or injury can cause adhesions to form and prevent this movement. Adhesions can occur almost anywhere in the body, including joints, such as the shoulder, eyes, intra-abdominal adhesions, or the pelvis. Adhesions can become larger or tighter over time. Problems may occur if the adhesion causes any organ or body part to twist, pull out of position, or be unable to move normally. The risk of forming adhesions is high after surgeries, with approximately 93% of the cases developing adhesions. Surgeries using laparoscopic is less likely to cause adhesions than open surgery. This section lists the surgeries a patient is likely to encounter. This is a current gastrointestinal assessment form, not a life history form. You should have a different form or patient notes for the patient's health history. Inform the patient to consider only their symptoms in the past 1 to 2 weeks. This form is scored with answers of yes or no and 0 to 3. 0 is least or never occurs, while 3 is most of the time or always occurs. There are several pitfalls to avoid in analysis of this form. The first is do not add up the numbers, as different queries in these sections carry different weights depending on the patient's condition. The next would be assuming that every patient has the same definition of 0 through 3. One person's 3 may be marked as a 0 for various reasons. For example, it is not one of their primary concerns. Another patient will have all 3s, but when asked on a severity scale of 1 to 10, will say that their condition that occurs all the time is a 2 on the severity scale. Finally, their primary health concerns should be reflected in the sections below. As you can see in this example, the person's primary concern is constipation, gassy and bloated, weight loss, pain, and brain fog. While in section 3, everything is a 0 except for bloating, which is a 1. This discrepancy must be discussed with the patient. It should be marked as this example of section 3 is, with the 3s matching their primary health concerns. A quick note, when it comes to queries about gas, women will not admit it, and guys think it is a badge of honor. Ask a spouse or someone who lives with them to confirm their answer. For those patients who mark all 0s or all 3s, make them do it over. This will show them you take this seriously, otherwise it is garbage in, garbage out. In section 2E, abdominal adhesion symptomatology, we are looking for those symptoms most often associated with the formation of adhesions in the body. This is covered in the adhesion unit of the Mastering the Gut program. Adhesion symptoms are often overlooked, and these queries are those which are most often an indication that adhesions are present and contributing to the patient condition. Section 3. Inulin sensitivity. Is inulin a friend or a foe? Inulin is an ingredient added to food either as a prebiotic or a natural sweetener. Inulin is now being added to an increasing number of processed food marketed as healthy, such as candies, beverages, yogurt, ice cream, chocolate, butter, and breakfast cereals. Some patients have an increased hypersensitivity to inulin. The increasing use of inulin as a food ingredient has led to a greater incidence of hypersensitivity. But if the food in this section caused any gastrointestinal distress, it would be attributed to being either lactose intolerant or the blame would be placed elsewhere. Symptoms of inulin intolerance usually include flatulence, bloating, cramps, abdominal pain, diarrhea, or constipation. This section allows the patient to answer queries on how they feel after consuming high inulin foods. Section 4. Oral Health, Infection, and Temporomandibular Dysfunction. Oral infection and dental procedures can cause transient bacteremia. Oral periogenic bacteria can cross into the bloodstream through the bleeding gums, causing a systemic inflammatory infection. These microorganisms that gain entrance to the blood and circulate throughout the body are usually eliminated by the Kupffer cells in the liver within minutes, and as a rule lead to no other clinical symptoms than possibly a slight increase in body temperature. However, if the disseminated microorganisms find a favorable condition, they may settle at a given site and after a certain lag time start to multiply. Poor dental hygiene is associated with more deleterious gastrointestinal flora, as they alter the gastrointestinal environment by translocation from the mouth to the upper digestive tract. Inflammatory complications of periodontal infections are associated with thyroid insufficiencies. An increasing number of bacterial species have been identified in intrauterine infections that do not belong to the vaginal microflora. Intrauterine infections can originate from the mouth following hematogenous transmission. The infection by periodontal pathogens induces a significant alteration in the architecture of the placenta, especially in the areas that are critical for the exchange of nutrients between the mother and the fetus. Periodontal disease either predisposes or exacerbates the insulin resistance or diabetic condition. H. pylori is frequently encountered in the oral cavity of individuals with periodontal disease. Periodontal bacteria are also associated with the occurrence of pancreatitis. Periodontitis as an infection may stimulate the liver to produce C-reactive protein, which in turn will form deposits on the injured blood vessels. This is covered in the Oral Health Unit of the Mastering the Gut program. Temporomandibular disorders affect the person's ability to eat, chew, swallow, make facial expressions, speak, and even breathe. TMJ issues are associated with a 112% increase in digestive complaints compared to the normal person. TMJ conditions have a definite effect on the ability to repair and restore proper digestive function. It is important to determine if the patient has an ascending or descending temporomandibular lesion. This requires a structural correction of the ascending or descending distortion pattern in order to restore digestive function. Section 5. Parotid symptoms. There are two large salivary glands. You have one in front of and just below each ear. Proctitis is inflammation of the parotid glands. The parotid glands, with the parotid ducts emanating into the cheeks, supplies a fluid containing digestive chemistry. Impaired salivary flow is harmful to health. Many bacteria express proteins that bind up with illegal saccharides present on the salivary mucins. Salivary mucins bind up multiple bacteria, and the agglutination that results protects the body from the bacteria. Inadequate salivary flow increases the incidence of dental caries. There is greater bacterial retention in the mouth in the formation of more dental plaque. The acids produced by the bacteria are inefficiently neutralized, and the enamel surface does not efficiently remineralize. Either one or both of the parotid glands can be inflamed. They can be inflamed for several reasons, including bacterial infection, bacterial biofilm creating a salivary stone, mucus plugs, Sjogren's disease, and certain other medical conditions, such as diabetes, alcoholism, and bulimia can cause problems with the parotid glands, but they usually do not cause infection. The symptoms depend on the cause of the parotitis. Symptoms can include swelling, pain, bad taste, and dry mouth. This is covered in the oral health section of the Mastering the Gut program. Section 6. Upper gastrointestinal tract and stomach-related symptoms. The arrival of food in the stomach stretches the wall, stimulating the wholesale release of stomach acid and enzymes. Stomach acid's first responsibility is to sterilize your food against alkaline-loving microbes. The stomach mashes and mixes the food with the digestive chemistry. As the food makes contact with the stomach lining, acid and enzymes are sopped up by the food. In this section, the patient answers queries regarding stomach and upper digestive tract symptoms. Gastric secretion is a fundamental step in the digestion and assimilation. Many clinical conditions originate with decreased gastric acidity. Gastric acid is necessary to activate the pancreatic enzymes and convert them into their active forms. Intestinal peristalsis and gastric acid secretions normally prevent excessive growth of bacteria in the small intestine. In order to repair and restore the digestive process, it is imperative to start with the mouth, going next to the stomach, and then to the pancreas and the gallbladder. Often patients present with symptoms that are related to another part of the body, referring pain as a result of one or more organs that are in distress. Visceral pain is gradual in onset, progresses in severity over time, and tends to last longer. Because visceral somatic pain is slow pain, patients will not be able to localize where the pain is. They will use a broad hand to show the location of their chief complaint versus being able to point to fast pain from nerve fibers. Each organ refers pain to different areas of the body. Section 6A is referred pain from the stomach. Section 7. Pancreas exocrine insufficiency. The pancreas is thought of as having different functional components, the endocrine and exocrine parts. The endocrine part is only 1% of the pancreas. The remainder is related to exocrine function. The commonest cause of abnormal digestion is the failure of the pancreas to secrete its juices into the small intestine. Lack of pancreatic secretion frequently occurs with gastric atrophy, atrophic gastritis, hypochlorhydria, or achlorhydria. Overproduction of inhibitory hormones or paracrine agents, increased sympathetic nervous system stimulation, or pancreatitis, where a pancreas stone blocks the pancreatic duct or gallstone at the ampulla vater. Loss of pancreatic juice means a loss of digestive enzymes. Without these enzymes, as much as 3/4 of the fat entering the small intestine may go undigested, and as much as 1/3 to 1/2 of the proteins and starches. It is also well known that endotoxemia, which is caused by bacterial infection, can contribute to pancreatitis. Bacterial translocation into the pancreas is an important cause of pancreatitis. Section 7A is pancreatic referred pain, with queries on how often the patient experiences pain in the left shoulder or between the shoulder blades, burning pain from the stomach to between the shoulder blades, pain and tenderness under the left rib cage, headaches in the temple area, or do they find that they sleep better when sitting up or sleeping with extra pillows? Section 8. Gallbladder insufficiency. Bile acids, the end products of cholesterol metabolism, are involved in liver, biliary, and intestinal disease. Formed in the liver, bile acids are absorbed actively from the small intestine. Primary bile acids are synthesized from cholesterol in the liver and secreted into bile. During this process, they are biotransformed into a variety of metabolites by gut bacteria. The major biotransformation is the conversion of primary bile acids into toxic secondary bile acids. This transformation is done by 2 species of high-activity strains of Clostridia. Testosterone markedly increases clostridial activity and the conversion of primary bile acids into secondary bile acids. This section has queries as to what symptoms the patient is experiencing that relate to gallbladder function. Section 9. Fat malabsorption. Fat malabsorption refers to the impairment of processing fat, which takes place mainly in the small intestines. The signs and symptoms of fat malabsorption can vary depending upon the causes and the severity of the condition. If fat malabsorption is left untreated, the symptoms could become more severe as the body continues to lose water, electrolytes, and other essential nutrients. Malabsorption treatment is aimed at addressing the underlying cause of the problem. Sections 10, 11, 12, and 13. Bowel habits can vary from person to person. This includes how often they have a bowel movement, their control over when they have a bowel movement, and the bowel movement's consistency and color. Does it float or does it sink? Alterations in any aspect of these habits represents a change in bowel habits. Changes in bowel habits can be caused by a range of conditions, from temporary infection to an underlying medical disorder. Changes in bowel habits are treated based on the underlying cause, and this form helps to identify it. Section 14. There are 7 types of stools according to the Bristol stool chart. The Bristol stool chart, or Bristol stool scale, is an aid designed to classify feces into 7 different groups. The types of stool or feces depends on the amount of time it spends in the colon. After the patient passes feces, what they see in the toilet is basically the end result of their diet, fluids, medications, and lifestyle. You can use the Bristol stool chart to check what their stools are telling you. Is the colon hypo or hypertonic? This can provide information as to the status of the NEI supersystem. Finally, the last block is for additional comments for the patients to type into. More information can be found on each of these sections in the Mastering the Gut program in the individual units